Good evening, everyone. I am Dr. Yogendra Shokin. Welcome you all on behalf of entire Merck Oncology team to today's meeting. So Merck, as we all know, is the world's oldest pharmaceutical specialty innovator company. We were founded in 1688, so we carry with us the legacy of more than 350 years. And today we have a proud presence in 66 countries. Next slide. So we have been pioneer of many concepts, particularly in metastatic colorectal cancer space. Our prime product, cetuximab, had been first to be approved as anti-EGFR therapy in metastatic colorectal cancer. Also, we were the first to personalize treatment in ROS wild-type metastatic colorectal cancer. We have been also the pioneers in role of tumor-sidedness, so the difference between left and right-sidedness of colorectal tumor treatment and its prognosis. Next slide, Prajik. We at Merck today proudly launches next generation sequencing testing for metastatic colorectal cancer patients. So this is a leap towards personalized treatment concept in metastatic colorectal space, and we come ahead for improving colorectal cancer care space in India. So in our program, there will be multiple options to enable biomarker-driven treatment in metastatic colorectal cancer. It can be tissue-based. So the tissue panel will include all NCCN recommended 12 genes, including KRAS, NRAS, BRAF, HER2, MET, NTRK1, NTRK2, NTRK3, POL, POLD1, RET, and DMMR, which is mismatched weight genes. So test will be done on NGS, that it will include both DNA plus RNA, and DDMR will be done by IHC. It has the fastest turnaround time of 7 days, which actually plays a very crucial role when it comes to NGS. In liquid biopsy, 9 genes will be covered, which plays a very important role. To the previous slide, Kushi. It will be KRAS, NRAS, BRAF, again ERBB2, which is HER2, MET, NTRK1, NTRK2, NTRK3, and RET. Test method will be again NGS on liquid biopsy, so it will also include DNA plus RNA. TET in liquid biopsy will be 14 days. RT-PCR tissue biopsy and liquid biopsy tissue biopsy will include KRAS, NRAS, and BRAF. As it was going on, it will still the option will still remain for mCRC patients. Next slide. So we at Merck are committed to enable biomarker-driven treatment in metastatic colorectal cancer patients. And this is going to be the core of discussion for today's meeting. Next slide. So the title of today's meeting is Precision Oncology in Metastatic Colorectal Case Treatment. So this is the series of events which is going on. And today we here are going to initiate North chapter. To chair today's meeting, we are honored to have Dr. Atul Sharma with us as a chairperson. Next slide. So as we all know, Dr. Atul Sharma needs no introduction. Presently, he is the vice chairperson, chairman of Medical Oncology Department in Max Super Specialty Hospital. But previously, he had been head of professor and head of Department of Medical Oncology at AIIMS. He has more than 350 research papers published in reputed national and international peer-reviewed journals. He had many awards under his belt, and today we are proud to have him as a chairperson of the meeting. Without wasting any further time, sir, I will request you to take the meeting ahead from here.
All right, thank you very much. Thank you, Eugene and the Mark, and good evening to my colleagues. And so this is an opportunity we are learning daily, and probably I do agree that Merck has been pioneer at least in the one of this indication metastatic colorectal cancer, where they launched cetuximab, the first of its kind of EGFR inhibitor. So my job is very brief, and everybody will be waiting or are waiting to hear. So next one, please. So, like he introduced this thing, so every time nowadays we are probably struggling to what should be the best treatment, and now the patients are living longer. Than there are multiple treatment options for the patients for the and many solid tumors, liquid cancer, and this thing. What does we have seen over a period of time, the increased complexity in the treatment decisions. So maybe that's with regard to the chemotherapy options are limited, but plethora of the drugs with regard to the precision oncology, precision medicines, targeted treatment, also that most of the time nowadays patients who are willing to afford and this thing, they go through the multiple lines of the treatment. And of course, this the least one can do with regard to the colorectal cancer, the RES, BRAF, MSI, HER2, and TRK, which have the agnostic value with regard to the particular treatment. So this now we also understand that over last couple of years we have been talking about the left and right. There may be a different tumor biology response to the treatment, different indication for the drugs. And of course, this is the over dynamic evolving field for the guidelines. They keep on changing. NCCN and for increasing emphasize biomarker-based treatment selection. And we observe and we follow this in our routine clinical practice. Of course, nowadays also we understand the sequential or continuum of the care. And now there are many subset of the patients who will likely to respond to one patient's particular, even if I say the care is wild type, it may not just be sufficient. There are different kinds of whether the mutation is at the G12C or different level may have a different meaning in this thing. So BRAF with 60, for example, mutate as the HER2 positive NTRK and so on. Next one. So what guides metastatic CRC treatment decisions today? Number one, first and foremost, we have to decide whether this is left side tumor or right side tumor. With the basic minimum workup does include the biomarker status with regard to the always BRAF, MSI, NTRK, and HER2. Of course, performance status, comorbidity of the patient, and past medical treatment are very, very important. And for with regard to biomarker, whether we do it the tissue biopsy, liquid biopsy, and the previous treatment and responses also. Next one. So this is the problem we are going to discuss. The updates reflect the evolving treatment landscape and the increasing role of biomarker in therapeutic decision making. And the ESMO Precision Medicine Working Group and consensus guideline focus on the following key areas. There's wild-type metastatic CRC, MSI high, BRAF mutant, and liquid biopsy emerging. Next one, I think this is the time to invite Ankur. Next one. All right, so these are the likely going to be the objective for today's discussion, which will be carried forward by Dr. Ankur and the colleagues to understand the evolving treatment landscape in metastatic CRC with a focus on biomarker-driven approach, to highlight the importance of NGS testing investigational workup to enhance therapeutic response in the colorectal cancer, to review current global guidelines for managing mCRC across first line, second line, third line, and so on, to explore treatment decision making for wild type CRC by tumor location, to examine sequencing strategies and efficacy of anti-GFR therapy in first line and re-challenge setting, to discuss personalized treatment strategies for the MSI high, BRAF mutant, and KRAS G12C mutant CRC, to highlight the role and use of liquid biopsy and real-world application of biomarker testing in Indian clinical practice. Next. So with this, it gives me, maybe that we can move previous slide. With this, it gives me immense pleasure in inviting Dr. Ankur to discuss it further and continue the discussion. Ankur,
Yeah,
you're
thank you so
welcome.
much, sir. Thank you so much, sir. It's my pleasure. Uh,
Next slide, Khushi.
yeah.
Yeah. So further. So thank you, sir. Thank you for giving a brief introduction about the colorectal cancer and also setting the context for today's meeting. You have very nicely highlighted the significance of next generation sequencing and personalized sequencing in colorectal cancer. And for today's session uh, speaker session on close look at the current treatment guidelines in metastatic cancer. We have Dr. Ankur Bahal with us today. Next slide, Khushi. So Dr. Ankur Bahal is presently the principal investigator of medical oncology in Fortis Hospital. So we all know about his contribution to improving cancer care in India. He is one of the most prominent oncologists
Yogender, we
in
can
India
move
space.
forward. We can move forward. Yeah.
Sure. So to have the honor, I would like to invite Dr. Ankur and take the first session on colorectal cancer. Kushi, next slide. Yeah.
Yeah,
Over to you, sir.
thank you so much, Professor Adul sir, and Mark and Dr. Yogender. So we are here to look a closer look, a deeper look at the current treatment guidelines in metastatic colorectal cancer. As far I remember, I've first seen cetuximab or Erbitux in colorectal cancer in year 2008 or 2009, practically at the ground level. It's an old molecule, but yes. So colorectal disease, as Professor Atul Sharma has said, that it has evolved. It has evolved over many decades from basic 5A few. Now we have many treatment changes, and we will be discussing the evolution, but we will be discussing the latest evolution. So our discussion will be revolving in last 2 3 years, what has happened and how there is a shift, or there's a thought concept in colorectal cancer. And Dr. Atul Sharma sir has clearly said that in solid oncology or hemato-oncology, and now in oncology, a good oncologist is that who knows what he will do further when the patient progresses. So our main goal is to give treatment in between, give maintenance therapy in between two major treatment, whether it is chemotherapy plus targeted therapy in the form of anti-EGFR or anti-VEGF, and how we can exploit the biomarkers in colorectal cancer. And we'll be discussing this evolution in next 8 9 minutes. Next slide, please. So as Professor Atul sir has said that ESMO Precision Medicine Working Group and consensus guideline was last laid and published in lower gastrointestinal cancer in 2022. So it is not a old, it is not a new concept. We have been, so liquid biopsy is a new concept, emerging biomarker is a concept, but for last one and a half decade, we are talking about pan-RAS, KRAS and RAS, and then BRAF. Then we have BRAF mutation. Lately, in last 3 4 years, there's a tendency from our side to detect those MSI high colorectal cancer, and then BRAF V60 is a specific mutation which can again be targeted with cetuximab, folfos, and encorafenib. And now lately, so when the tumor is progressing, very rarely it happens that in colorectal we don't get a tissue, but there is an evolving concept that liquid biopsy, it usages, the resistance form, what will happen, the Chronos trial, the Cricket trial, the re-challenge of the previous drug, and identification of a new clone. So, and the emerging biomarkers, which are, I think, yet to be discovered. Many biomarkers will be discovered in next decade or so. So, what on what basis we have to revolve our treatment? So, basically, the goals of colorectal cancer, if not laid on the first diagnosis, it could be a metastatic bilobar liver disease. It could be few metastases in one lobe or few metastases in both the lobes, oligometastasis, more than oligometastasis. So we need to know our goals. What would be the goal of this patient? We want a palliative care. This patient will never be resected, or we want early treatment response, ETS. We want duration of response. We want to convert this metastatic disease into a surgical one, whether it will be a stage resection or in a very fit patient we can do both colorectal and liver surgeries together. So there are many factors. Cost is a factor, performance status is a factor, left sided, right sided is a factor, presence of MSI high status or any co-mutation, actionable mutation, resistant pathway. There are many things which come in a pathway of colorectal. And with this exercise, we are now able to say that 5 year survival in a metastatic colorectal can be up to 20 30% or beyond that also, if we utilize all the three specialities, which is medical oncology, surgical expertise, if we able to use local control in the form of RFA, SBRT, ablation, metastectomy, hepatectomies, and all those things. So coming on to the topic for today, which is more or less palliative. So we are talking that it is a non-resectable. The treatment approach is palliation, and we have to juggle between the drugs, which drug to be used, chemotherapy with which targeted therapy. So let's talk about this. So recommendation for optimizing the treatment of left-sided RAS wild type colorectal. So we are specific here that we're talking about left side of the colon cancer and which is not mutated. KRAS, NRAS, and BRAF are wild type. Next slide, please. So this is a ESMO. So stage 4 unresectable wild type RAS and BRAF wild type and first line of therapy. If it is a left-sided colon, a CT doublet 5-FU pyrimidines with platinum with anti-AGFR is the drug of is recommended in left side. However, in right side, when the disease in the right side, still chemotherapy doublet plus minus VEGF inhibitor bevacizumab, or we can use triplet. There is a data on triplet with or without bevacizumab. But if the tumor shrinkage is the aim, you want that those liver metastases which are may not be resectable or a borderline resectable, and you aim that ETS early tumor shrinkage should happen. So if the patient has is wild type KRAS wild type, then probably chemotherapy doublet with an anti-EGFR, which is cetuximab, or any other EGFR inhibitor. The guidelines still have I have personal inclination that if the disease is resectable or we are waiting, so 2 months of this CT doublet with anti-EGFR, do not let metastasis disappear, then we can have a goal. So guideline reflects earlier findings from 2017, the Arnold and Hall pooled and meta-analysis, that even in right-sided colon, if you have a KRAS wild type, you can think of anti-EGFR and a CT doublet, particularly when you want early tumor shrinkage. And practically, when you're thinking about shrinkage, bevacizumab usage is less. So you have to use bevacizumab 6 to 8 weeks either side of the surgery. So we might not get that much efficiency. So in my thing, if the patient is KRAS wild type, left side or right side, if and surgery is the goal, I would not hesitate to use CT doublet and anti-AGFR, and the meta-analysis and the recommendation also are inclined towards this state. Next slide, please. So broad evidence supports that the use of this cetuximab or Erbitux with chemotherapy is the standard first line treatment. So it has showed in Crystal Prime and Taylor trial that there's a OS overall survival, progression free survival, overall response rate when cetuximab is combined with chemotherapy versus chemotherapy alone. And if we see the other side in left side tumor, there's a Fire 3 CalGB SWOG and paradigm which showed that OS and overall response rate with anti-EGFR when it is compared with bevacizumab and chemotherapy. So Fire 3 CalGB and Paradigm has actually compared anti-EGFR agents with bevacizumab and chemotherapy. However, in Paradigm, the other EGFR panitumumab was being studied. Next slide. So different phase 3 trials in first line anti-EGFR and a doublet chemotherapy gives a overall survival benefit. We can see in Fire 3 trial there's a delta of 10 months with the p-value being significant, and overall response rate 79 versus 68%, hazard ratio 0.71. In CalGB SWOG there's a delta of 6.7 month and hazard ratio of 0.77. And in Paradigm, when it was compared with anti-EGFR and a chemotherapy with anti-VEGF and chemotherapy, so again anti-EGFR panitumumab and Folfox has slight edge over bevacizumab and Folfox in Paradigm 3, and again hazard ratio is 0.82. So this clearly signifies that chemotherapy with cetuximab or chemotherapy with anti-EGFR is better than chemotherapy alone. And in paradigm shift, there is a slight inclination if you use anti-EGFR with chemotherapy. So there is a data which says so there are many data which suggest either side also. But yes, when ETS is a goal, when left sided is a goal, and KRAS, NRAS, and BRAF are wild type, think about cetuximab and chemotherapy agent. Next slide, please. So in paradigm trial, the OS actually crossed at 28 months. So this shows that, so we see the right side of the graph, the paradigm left side RAS type, wild type tumors. So panitumumab and Folfox, there the curves are crossing and at 28 months, and then they are splitting. And in Fire 3 and CalGB, it is also documented that chemotherapy and cetuximab is better than bevacizumab and chemotherapy. So graph clearly suggests that anti-EGFR and chemotherapy slightly have a better edge when it's come to left-sided. And when you have a ETS as a goal, when you want to do surgery, then even in right-sided, this is beneficial. Next slide, please. So this is a ESMO guideline also recommend that treating the targeted agent until disease progression. And we know that in our practice, maintenance therapy is a goal. Whatever you have given first line, decrease the toxicity of chemotherapy and give 5-FU or capecitabine and a targeted therapy anti-VEGF or anti-EGFR, Valentino study, Panama study, Macro 27 study. So there are many studies which have said that a maintenance therapy with 5-FU pyrimidine or capecitabine gives a survival benefit when it is given beyond when chemotherapy has done its effect. Next slide. So this is these are the maintenance strategies, and we have been discussing these maintenance strategy: Panama, OMS trial, Nordic trial, Macro 2, Macbeth, Valentino with panitumab, Sapphire, Prodage, and Primally. So many phase 2 and majority of them are phase 2, and Nordic 7 was a phase 3 trial where various combination of anti VEGF inhibitor in the form of cetuximab or panitumab alone or with 5-FU pyrimidines or capecitabine, they have been studied, and there's a quite a good data with this meta-analysis showing a conclusion that 5-FU pyrimidine plus anti-EGFR can be considered a valuable maintenance option in RAS wild type colorectal cancer, and EGFR monotherapy can be considered, especially in left-sided tumor and when patients have long-term toxicity. So we have seen in our clinical practice, maintenance therapy is a rule. There are many patients who are doing so good only on cetuximab and capecitabine or cetuximab alone in right-sided, left-sided tumors. Next slide. So now, as Professor Atul sir rightly said, that we as a medical oncologist always should have in mind what we will give next, and now we also have in mind what we will go next to next. So to cetuximab followed by bevacizumab or bevacizumab followed by cetuximab. Let's deep down the data. What is the beneficial role of this sequential? Next slide. RAS, so let's take one by one. RAS wild type, left side colorectal cancer. If first line is given cetuximab, then second line approximately 50 to 70% do continue with second line if performance status and patient mindset and the doctor mindset agree. Then we can give bevacizumab or chemotherapy as a second line, and we have many options in third line also. We have regorafenib, we have Lonsurf, frequentinib is coming, and rechallenge of those and the previous protocol if the DFS is larger. So this is an indirect comparison of various trial. If we go this way, Cetuxi chemotherapy followed by Bevasi chemotherapy and followed by some third line, we can achieve a overall survival of 40 months. However, if we give bevacizumab and chemotherapy first line and then switch to cetuximab, panitumab or chemotherapy in the second line, and then we give a third line, whatever it is probably lesser. This is an indirect comparison, and bevacizumab plus chemotherapy and then you continue bevacizumab plus chemotherapy, you haven't given cetuximab in a RAS wild type, and then you switch to Regora, Lonsurf, or some other agent, frequentinib or rechallenge. So then my survival is to the tune of 20 to 23 months. So this is an indirect comparison which says that if you choose your basic biomarker right, choose left side, right side, right, and then you choose the sequence. If you choose orange first then gray later, or a gray first then orange later, you might have a survival advantage in direct comparison between 40 months, 28 months and 24 months. Next slide please. So in left side wild type tumor, re-challenge of cetuximab in third line and beyond, which I have said in my previous line, majority of time. So there is a theory that the resistant pathway comes, and if you give bevacizumab in between, and then patient who progresses on, suppose we have given Folfox cetuximab, then we give Folfiri bevacizumab, and in rebiopsy, if KRAS is wild type is maintained, we can again re-challenge with cetuximab. There are many studies to it. So patient might survive better than continuing bevacizumab alone. Next slide, please. So this is current ESMO guidelines for third line, and these kind of patients are actually increasing day by day in our practice. We have TAS 102 and bevacizumab, the Sunlight trial, single agent anti-EGFR monoclonal antibody, panitumab or cetuximab, irinotecan and cetuximab. I would not hesitate to say oxaliplatin and cetuximab if patient does not have previous neuropathy and there are 2 years of DFS. TAS 102, regorafenib, frequentinib is additionally recommended very lately in ESMO and even in NCCN guidelines. So it clearly said that our colorectal cancer, if treated properly in the first line and second line, if the quality of life is maintained and we have an option to give third line treatment in colorectal cancer is not very rare in our practice. So 20 to 30% of our patients actually take third line and fourth line, and we have plenty of real world evidence and our own personal experience with third line and fourth line also. Next slide. So I have said re-challenge clonal evolution. So we can say that the pink ball are more, the pink ball become less, and again pink ball become more. So there is always a chance that if we give an anti-EGFR agent upfront, then there's a cetuximab or panitumab free interval, and then later on when the patient progresses, and if you re-challenge with anti-EGFR agent, this is a proven theory of clonal evolution in colorectal cancer. Next slide. So treatment in RAS wild type right sided. So as we said that if your ETS is the goal, your resection is the goal, you want early tumor shrinkage. And these terms were very earlier framed in around 2013-14 in Cohen trial, Fire trial. If we want to resect these tumor early, do not let them disappear. Do a next CT scan within 2 months and operate them. Do not let the liver metastasis disappear and do a hepatectomy or a metastatectomy or a stage anatomical resection of the liver with surgical resection of the colon. That might give you a survival advantage. Next slide. So this is a MRC guideline recommendation, and we have discussed 2022 ESMO guidelines, cytoreductive, higher responsiveness for conversion therapy, so anti-EGFR and doublet therapy, ASCO guideline 22, ESMO pocket guidelines, and 18, if you go behind 18, ESMO Pan-Asian guideline, clearly said if you want a higher response, if you want a cytoreduction, and I personally believe with bevacizumab, you are able to give just 1 or 2 cycles. You can convert them to a surgical resection if that is a goal. And EGFR agent, anti-EGFR agents with combination chemotherapy give you a high response rate, and early tumor shrinkage can be achieved. Next slide, please. Next slide. We have discussed this. Next slide. Crystal, Taylor, CalGB, Fire, 3Coin, they all have documented this concept of early cytoreduction and then achieving surgery. Next slide. We have already discussed ETS in patient with RAS wild type colorectal phase 3 Fire trial. So cetuximab and FOLFIRI achieve 50% of the patient achieve early tumor shrinkage and overall survival in patient with those patients who have got more than 20% early tumor shrinkage, they survive for 27 months. However, if we rely on bevacizumab, this number can be indirect comparison of close to 23 months. So 41% of patients achieve ETS. So what I've been talking for last 10 minutes is that if this is the goal, even in right side, consider cetuximab and doublet chemotherapy. Next slide. So the recommendation for targeted therapy are amazing. I will say a bit late in getting those solid and NGS. So medical oncologists are tuned to get this tissue NGS or hotspot colorectal panel, and now we are coming with liquid biopsy and RT-PCR based test, which can give a TAT of very as close as 3 to 5 days, where we can decide. Usually, we wait for the second cycle. We start with this doublet chemotherapy. In second cycle, we'll add the targeted therapy. I think if we can wait for 3 to 5 days, and if the TAT is early, we'll be able to give a targeted therapy with doublet chemotherapy upfront while patient are getting their scans and getting echocardiography and getting a daycare date also. Next slide. So this is the first line, breakwater beacon or a keynote 177. If you have a MSI high, go for immunotherapy. If you have a BRAF mutation, go for encorafenib, cetuximab, and Folfox. on the basis of breakwater, break-on study. And if you are mutant, and if you are giving to give bevacizumab, if progressive, not progressive, give maintenance. If progressive, switch to second line. So this phenomena is well known to all the medical oncologists of the country. Next slide. So second line, we have already discussed. Whatever you have used first line, if the anti EGFR allows you, if the patient is wild type, use anti EGFR. Otherwise, continue bevacizumab. Change the chemotherapy arm, and then reintroduce the second line, third line on the basis of KRAS G12C mutant. If the patient is MSI high, then you can use immunotherapy, Iplunivo or Pembro alone. If you discover BRAF or V600 in the second line, still you have a chance of giving a anti-EGFR and encorafenib, and RAS wild and anti-EGFR we have already discussed. Next slide. So tissue and liquid. So when quick responses decisions are required, you have in liquid biopsy, you have a low TAT. The result can actually begin in 5 to 7 or 10 working days. Very rarely it happens in colorectal cancer when tissue testing is not feasible, patient not agreeing, or liver cannot be biopsy. And then very important, when considering for an anti-EGFR challenge, before giving third line cetuximab, just check KRAS and RAS wild type. If the wild type is still there, you can give cetuximab as a third line therapy. And we have discussed it might give us 3.5 years overall survival. Next slide. Next slide, please. So to summarize, Professor Atul Sharma has already summarized. So updated guideline recommend that tailoring first line treatment according to tumor sidedness, performance status, goal of therapy is very important. Anti-EGFR and a chemotherapy agent is now recommended as the only option in left-sided RAS wild type, as per ESMO Living 2024 guideline. So tuximab and chemotherapy may offer a 40 months overall survival if sequenced right. So tuxi chemo, bevacizumab chemo, and if given an opportunity of third line reintroduction of cetuximab, we should continue anti-EGFR as a maintenance therapy with the, if you are left-sided, monotherapy. If you're right-sided, or patient fitness allow, with capecitabine or with 5-FU pyrimidines. In right-sided, consider anti-EGFR chemotherapy when your goal is early cytoreduction and you want to resect those liver metastases. And it always important to consider other recommended option as per the guideline. And our main goal is to improve patient outcome, and our patient should live longer with a good quality of life. So I think with this brief last 10 minutes discussion, I'm very keen to listen Dr. Manish Singhal as a moderator for a panel discussion. Over to the organizers.
Thank you so much, Ankur sir, for your comprehensive presentation. So very nicely you covered the contribution of multimodal treatment, including radiotherapies, surgery, and of course, medical oncologist. You have very nicely covered the significance of biomarkers and sidedness and how they have been incorporated into the guidelines. So whether to see that these guidelines and all this data which is presented by him actually make a sense in and make a difference in clinical outcomes in clinic. We have with us Dr. Manish Singhal with us. Next slide. So Dr. Manish Singhal is senior consultant of medical oncology in Indraprastha Apollo Hospital, and we all know about his contribution. And he had been the first and only gold medalist in
No,
certified
I'm
medical
not the
oncologist,
only
sir.
now. No, I'm not the
Okay,
only now.
okay, sir. So
There's another one who has stopped the exam last year.
wonderful. So that's great to know. So without wasting any further time, sir, I'll
Yeah,
invite you to
I'll
take the panel
yeah.
discussion and moderate the
So
session.
thanks, Ankur, for that very elaborate and thorough discussion and your presentation on colorectal cancer. I think you've covered everything, and all the clinical data has been put forth now in front of us.
So
And now is
all the medals are given to us by Professor Atul sir.
yes, that's true, sir.
Yes.
That's true. I still recall those times of All India Institute of Medical Sciences. I think many of us have been trained by Professor Atul, and I still really when I think of those times, ऐसे लगता है उसे कल की बात ही थी और अब कितना टाइम बीत जाता है पता ही नहीं चलता है. So many years have passed by that it appears that we were just, it appears that it's just about yesterday's thing that we are discussing about when we were in AIMS. And yes, they were very, very good days. And thank you so much, sir, for training us in medical oncology. And think whatever we are because of you and the other teachers who had taught us. And my much gratitude to you. And with this,
Thank
I'll
you. Thank you.
yeah, thank you, sir. Thank you so much. And yeah, of course. So I'll take this discussion forward now. Of course, the data is there, and how we personally interpret this data, and we put forth to our patients, and how do we extend it to our patients? What are the bottlenecks that we face? What are some prejudices that we have? We may have some prejudices. We may have some concerns. I think that is what the discussion is all about. This particular panel discussion. And so we have the very erudite panelists, Dr. Rajat Bajaj, Dr. Shafali Sardana, Dr. Sumit Goyal from RGCI, Dr. Shafali is from Max, Dr. Rajat is from Fortis, Dr. Javed is from Kashmir. Thank you, Javed, for connecting from Kashmir. And Dr. Priya Tiwari is from Artemis. I hope all of them are there.
Yes, we are
Priya,
there.
Yes,
yeah,
yes, I'm there. Yeah.
Priya is also there. I
Yes, sir.
don't
Ma'am
hear
is
her.
there. Ma'am is there.
Ma'am is there. Okay.
Yeah.
Can we go to the directly to the slide set? So I think so. My first question is: do you really consider sidedness? Dr. Ankur did discuss about that. He may not really consider sidedness if it comes to response, and if you have to achieve response. So I'll ask Rajat. Rajat, how do you interpret that information? You have a RAS wild type, BRAF wild type population, HER2 non upregulated, MSI stable. What else? Yeah, this is what the case is. And you have a right-sided tumor, and it is a liver metastasis, not resectable, never resectable. So Rajat, how would you approach? Would you or potentially resectable? Sorry, I'll put it as potentially resectable. So would you consider doing um, waiting for, or you'll start with Folfox, and how do you do it? I don't hear from him. So I'll shift this question to Dr. Sumit.
Yes, Dr. Manish. So,
Hi, Sumit.
hi. Yeah, good evening. Good evening, everyone. So the question is whether I will consider sidedness to titrate my therapy or to sequence my therapy. I
So if
think
you
in
can,
today's
dwell on both, if this is resectable and this is not resectable.
okay. So unresectable, probably it is clearer. Definitely, I will look into it. So my goal is clearer. I need to prolong life as much as possible, and sequential use of medicines will be important for me. And we know in right-sided in first line, maybe the responses are not as good. So I may keep it reserved for the second line in unresectable metastatic right-sided tumor. Left-sided RAF wild type, definitely I will use it along with the chemotherapy and cetuximab. I will use in the first line therapy. And if it is like uh, the other thing is potentially resectable. So potentially resectable, it will again depend upon the sidedness. So we are talking about RAF wild type. So if it is a right-sided tumor, so probably I will think a lot whether to add EGFR inhibitors in this setting or not. Probably I will use a triplet if the patient is fit.
Excellent. And we know that the triplet study, which was a phase 3 study, did not result into any improvement with an
Yes.
EGFR inhibitor therapy. So that means you are not likely to gain if you were to use a FOLFOXIRI in the background of EGFR inhibitor
Yes.
by neither improving the overall response rate or the PFS or the overall survival.
Yes. So I will probably use FOLFOXIRI.
FOLFOXIRI, if there's a fit patient,
Yeah, if it's a fit
right-sided
patient.
tumor,
Yeah.
you'll use FOLFOXIRI. I think that is what the Cairo 5 also told us. The
Yes.
Cairo 5 told us that FOLFOXIRI plus bevacizumab in an otherwise upfront unresectable metastatic breast cancer, metastatic colorectal cancer. No, I was not in a breast cancer meeting before this. So metastatic colorectal cancer, it did not result into, so that was their favored protocol. The FOLFOXIRI plus Bev was their favored protocol, even for a right-sided tumor. I'll take this question now to Shifali. Shifali, what do you
Yes,
say?
sir. Yeah, I agree with Dr. Sumit. In a potentially resectable where you know that, say, suppose liver mets are there and you are going to resect it maybe in a stage surgery, I would avoid anti-EGFR here. Only in the cases where conversion is an issue, not a stage surgery by the virtue of, I mean, selecting the biology. Where conversion is an issue, conversion is an aim, I would try to add anti-EGFR for the better response rate. And if it is unresectable, I would go for a bevacizumab-based regimen and do.
No, but if it is resectable, potentially resectable, surgeon says, थोड़ा कम कर दो, हम देख सकते हैं, we will
Sir,
consider.
for example, we have had the cases where there were 5 liver mets, very small, and they were located in the one lobe. But because of the biology, because of the selection of the thing, the surgeon was confident that if they are going to resect, it is resectable. Conversion is not the aim. There we use triplet because in a young patient, the aggressive biology is there. Potentially resectable, we use triplet.
Let's
Now
keep it
there,
simple. Shifali,
yeah,
let's
let's
keep it
keep it
simple.
simple.
FOLFOXIRI, Bev, or FOLFIRI plus, or for that matter, FOLFOX plus cetuximab, right-sided, all RAS wild type, potentially resectable, not upfront resectable, potentially resectable. Which one do you choose?
Folfoxiri. If the surgeon says conversion is not the aim, folfoxiri,
Any
triplet.
any any targeted therapy?
No. If no conversion is not the aim, no.
If conversion is the aim, then
Then yes, response rate is my first priority. So I would add on anti-GFR here.
if you add anti-GFR, you'll add with FOLFOXIRI or FOLFOX or FOLFIRI,
Doublet.
doublet only. So that means you are going with cetuximab based therapy, and
Yes.
our Dr. Sumit is going with a FOLFOXIRI plus Bev combination.
Maybe FOLFOXIRI alone, Bev plus minus.
Bev plus minus. No, there should not. Priya,
Hi, sir. So I
I
agree with the speakers. Sometimes I think we all just
there's some
adopt.
dichotomy there. You
Yes.
can't agree with both of them.
So okay. So see, sir. Sometimes when I'm looking for the conversion, I usually cetuximab I never use with triplets.
Of course not.
Mm.
So
Yes.
now we have a
So
phase
we
3
don't do
study.
it. My
Yeah.
only concern sometimes is, and I do triplets a lot when I want good response in a patient who is fit. But sometimes when there are liver metastases and I need to reduce the liver burden, sometimes I will just do a doublet chemotherapy along with the target therapy. The problem with triplet chemotherapy is it could be liver toxic it could be hepatotoxic for the residual liver volume.
Yeah, I
So
agree with
I
that
tend
point.
to prefer, I tend to
I
prefer a
think
double.
Professor Atul wants to say something.
Manish, yeah. So I just wanted to understand because Ankur was talking and you probably also reviewed it. So three drug versus two drug plus cetuximab in EGFR wild type, right-sided when the conversion is aim, and obviously we are looking for the faster response rate in this thing. Early tumor shrinkage as well. So which combination is likely to give you the better and faster response?
So, to my mind, if the patient is very fit and can take a triplet regime, I would look at a triplet regime plus a bevacizumab, provided there is no risk of a burst abdomen,
For this thing. Yeah.
yeah, a
I think
burst
I would
abdomen or
also,
something. And
when
I
the
would
rest,
look at a triplet regime plus a bevacizumab going by the Cairo 5. And because that was a head-to-head comparison between four arms. There's no other head-to-head comparison like this in any other study, which I believe there's no other study like that. But yeah, the point of contention over here is that whether you will use a, if there's a borderline-ish performance status patient, I would use Folfox plus cetuximab or a Folfiri
two
plus
drugs.
cetuximab.
Correct. Agree.
But if there's a young, robust patient, I would use with the Folfox Siri plus bevacizumab. Now I think our confidence of FOLFOXIRI has increased over a period of time with PRODIS 23 coming in for the rectal cancer. I think we know the knack of using a triplet regime. There used to be a fear of using triplet regime for patients who can go into a lot of toxicity. Now with the PRODIS data of the pancreas, PRODIS data of the rectal, more people are quite conversant with using the FOLFOXIRI. That is my take. So I think that fear has gone down.
100%. Yeah, 100.
Yeah. So I think I would use for a triplet regime with bevacizumab in a patient who is otherwise fit. If there's borderline-ish, I cannot use a triplet. I would rather go with cetuximab-based therapy with a doublet therapy. This is what I think. Priya, you were saying something.
So I was just highlighting the point that whenever we are using a triplet chemotherapy for somebody who has liver metastasis and planning surgery, then we have to be watchful and mindful about the toxicities on the liver, residual liver disease.
I fully agree with that point.
Yes.
I think when you discuss this point with any surgeon, they would
Yes.
say that don't overtreat.
Yes.
Do the
Yes.
surgery at the right time. Don't delay too
Yes.
much.
Yes.
Don't go to the 8th cycle because there
Yes.
is definite some liver toxicity and you might
Yes.
end up, having a liver failure type of a
Yes.
situation. And so I fully agree with that point. Dr. Javed, what's your take, sir?
Yeah, good evening, everyone. Good evening, Dr. Manish. So, what everyone said, I will summarize. So, they have, what it is, they have highlighted the data. So, on the right side, if we are looking for the surgery, it is convertible. So, triplets, or you give doublets with anti-GFR if RAS is wild type. And left side, yes, definitely, there will be stoxmap, whether it is unresectable, whether it is resectable, this potentially resectable. So there is no confusion. So left side, but one thing is there, what we say that surgeons, and we have talked to many surgeons, that once you give more and more irinotecan, this irinotecan induces more statosis. The surgery would be difficult if you give triplets, if you go for 8 cycles, what you said. So before 4 or to 6 cycles, we should limit our triplets and go for the surgery if possible. If not, then you have to go back fall to doublets.
Right. So definitely, I think Priya has brought that point, and this has also been corroborated in literature. And if you talk to a liver surgeon who does very routine liver surgery, they will say that don't overtreat with too much chemotherapy because that can compromise the liver function, and they may have their problems in resection.
So what we
So that
do is, Dr. Manish, one point
yeah,
only. What we do generally is when we are using FOLFOXIRI, we just assess after 4. And if we see that there is a good response,
so
we'd go for
you
surgery
start
and then
preparing and you just
de-escalate.
give 1 or 2 more cycles. Yeah,
Yeah, yeah. So then we de-escalate. If there is a
yeah,
good response, it is surgically resectable, done surgery. We de-escalate in case of a good response.
right.
Um,
Excellent.
Manish, one point.
Yeah.
So if we compare FOLFOX or FOLFIRI plus bevacizumab versus FOLFOX plus cetuximab or panitumumab in first line, the response rates are not great. They are the same. The overall
Response
responses
rates.
are
Yeah.
the same. So
Uh,
when we talk about conversion therapy and adding cetuximab in the right-sided tumors in the first line, but the responses rates are almost same, whether we use the bev or the cetuximab.
Sumit, I fully agree with you. The phase 3 study, the FIRE 3 study, the
Hmm.
primary endpoint was overall response rate.
Yes. Hmm.
Unfortunately for cetuximab, the PFS was improved, but the
Hmm.
overall response rate, which was the primary endpoint, was not improved.
Yeah.
Whereas
So
in the other studies where PFS was the endpoint, the PFS did not improve, the overall response rate improved.
exactly.
I think cetuximab has been very unlucky that
Yeah.
way.
Hmm.
Whenever they set the primary endpoint as something, they lost that primary endpoint of the
Hmm.
study,
Hmm.
but they proved the other
Hmm.
endpoint, which is the
Yes.
secondary endpoint.
Hmm.
Whenever they try to prove the other endpoint, they lost that endpoint, they proved the other endpoint.
Yes.
So it happens. It just kept happening for
Yeah.
cetuximab. I think they could not get around that benefit. I think
Hmm.
the paradigm study was the only study which showed very clearly in the left-sided that EGFR inhibitors is to be
Yeah. So left
focused on
side
the
there
left
is no
side.
debate.
And
Left side it is there is
there's no
no debate.
confusion.
Yeah.
There's no
Hmm.
debate.
Yeah.
So I think it's only on the right side.
Right.
Now,
Yes.
now Now, there was another question in my mind which I forgot discussing with you. Yeah. So now explain me one thing. Rajat, if you are there, can you just give your comment on the previous question, and then we can go to the next.
Yes, sir, I'm there. Good evening, everyone. So I think I agree with almost all the panelists have said in unison that left side there is no debate. Right side, uh, although I would say that in the conversion therapy there is data for cetuximab, but then I
That is a
still would
derived
go for a
data. That is not the upfront data.
yes, agree. So I would still go for a triplet along with VEGF inhibitor.
Along with VEGF inhibitor. So, any challenge that you face with a VEGF inhibitor? Any challenge? Any challenge, or I would say that any hindrance or any fear that you have with a VEGF inhibitor?
So are we talking about a patient where there is no contraindication to BEV?
There's otherwise no contraindication. Is there any fear factor in your mind? Because you have to withdraw the therapy just before the surgery, wound healing problem, etc., etc. Have you feared? Have you do you fear using a VEGF inhibitor anytime in
So
colorectal cancer?
I don't really fear, but the only problem is that it's a practical problem. Everybody would agree that in the first cycle we don't have the genetic mutation which has come up, and in the fourth cycle, just before surgery, we don't use bevacizumab for obvious reasons. So we end up using it only in 2 cycles. So now, if you've got a response after 4, then whether we are actually attributing it to the addition of bev, or is it only the triplet which is working, which we don't know. And the other point, this is practical aspect of it. The other point is that even in the clinical data, in the scientific data set, there also whether the addition of bev is actually making any difference to the response rates is something which is debatable and has been seen different in different data sets that we have.
Right, I agree with that point. So now coming to, say for example, now you have a situation where there
Dr.
is
Manish,
only,
just one point here.
yeah.
So,
Priya, yeah.
so I'll just share my experience here. I just had a patient. He had KRAS mutated sigmoid colon cancer, and we gave him bevacizumab based chemotherapy. And there was what we missed was that that sigmoid mass was actually touching the bladder, and he ended up with perforation after bev. And so there was a fistula there. So I think the scan has to be reviewed very thoroughly whenever you plan a
Very thoroughly.
bevacizumab.
I am very scared. I have burnt my fingers the way you have
Yes.
done it in
Yes.
the past, and I'm now fearful. That was the reason that I was asking Rajat.
Yes.
Yeah, are you fearful? Because I am fearful.
Yes.
Because once you burn your fingers like that,
Yes.
after that you will never, you will be extra cautious
Yes.
because
So
it's
the scan
horrendous.
needs to be seen very carefully whenever you plan bevacizumab.
Yeah, I agree because you just have to burn your fingers once, and
Yeah.
once that happens,
So
you
that
are
loss of fat planes,
overcautious.
that
You are
statement.
circumspect after that forever.
Yes.
So I
So,
agree with that point.
Manish, one more point. So, bevacizumab, we don't know. We know it is a slow to act drug. Basically, it is a VEGF inhibitor. It will work slowly.
It
So,
works slowly and it works when you keep giving it for a long duration of
exactly.
time.
So, how much impact it is making if you are giving only 2 or 3 cycles, that we don't know. So,
That we
time
don't
to
know.
tumor response again is a factor. Whether it is really making an impact, what Rajat said earlier. So, 2 or 3 cycles are they enough to judge the response of bevacizumab along with the chemotherapy?
So that is a problem. So you generally are able to give not more than 4 cycles.
Yeah,
And if it's a
exactly.
right-sided, you'll go upfront with FOLFOXIRI plus BEV without any question and keep cetuximab at the
Yeah.
as a back burner option. That is exactly. So we'll go to the next question now.
Yes.
So if you have a situation where I'll ask Sumit you only. If you
Yes.
have a situation where there is no question of any surgery and no conversion, and you have a left-sided tumor, you are using a Folfox plus cetuximab. So how long do you give this regime? What is your strategy to use the regime? Uh,
Yeah.
you close at 6 cycles, you close at 8, you go up to 12. And what is your maintenance strategy?
Yeah. So my strategy is not fixed. Basically, I look at the responses. So usually I try to go till 8 if there is no neurotoxicity. Most commonly we use
Excellent.
Folfox as the first line. And if there are ongoing responses, so I may go up to 12 cycles also. If there is just like plateau of disease and no much of benefit, probably I'll stop at 12 and may continue with maintenance cetuximab
So
along
what
with
is your maintenance?
5-FU leucovorin cetuximab. That is what I tell my patients, and that's what I try to give.
5-FU leucovorin and cetuximab.
Yeah.
Shifali, what's your maintenance?
Yeah, same.
And when do
5-FU
you stop?
leucovorin. 5-FU leucovorin and cetuximab till progression.
Okay, Javed. Dr. Javed, you have to unmute yourself.
Sorry. So with stoximab, I give capecitabine, and with panitumab, I give 5-FU CLV.
Okay. And you stop at how many cycles of
12,
Folfox?
at 12
12,
cycles.
12 cycles. Rajat. Priya, Dr. Priya.
So, so no, in such a patient, he started on cetuximab and 5-FU, I'll do capecitabine and the cetuximab.
Now
Maintenance.
going back to Sumit. Sumit, any concern of cetuximab combination with capecitabine?
See, one is the sequence it becomes when to call the patients. So 3 weekly
No,
was
this combination of capecitabine plus cetuximab, does it render any concern or does it not? Because
the
I'll tell you why. Any
Not
study which has been done.
synergistic. Yeah.
Yeah, there is a data that the patient did worse on this combination
correct.
as
Yes,
compared to
yes.
yes.
There is some evidence in literature that cetuximab, and that was
And
one
capecitabine,
study that was one concern why the EPIC trial, the new epoch trial, so
new,
not the
yeah,
EPIC, the new epoch trial actually failed because they used cetuximab. And I think when Custom had Eric Van Custom had reviewed this and written an editorial that you should not be combining cetuximab and capecitabine because there is some concern. They could not prove why,
yeah,
but they have some concern that you should not combine cetuximab and capecitabine.
yeah. So that's what we do. And the second thing is, if I have to use maintenance, the patient is not willing for 5-FU leucovorin, probably I'll give capecitabine alone. I will not give EGFR inhibitor.
Yeah, same. Same. I do agree, sir.
So my only question over here is there is a study called the ARMIS study, which is a phase 3 study. We use FOLFIRI plus cetuximab and continue to use FOLFIRI plus cetuximab in a continuum of care
Yes.
situation and showed that there is a good progression-free survival benefit.
So
Why start
Manish,
with Folfox? Yeah, hi sir.
Manish, I just wanted to contrary to everybody else when my aim is to continue treatment as long as possible instead of using Folfox as a first line treatment where after a
Exactly,
couple
sir.
of
That
signs
I was
is
coming to that.
yes, I prefer to use Folfiri plus cetuximab or this thing and I continue as long as patient is tolerating.
Right. So I was coming to that, sir. ARMIS study is a study which used FOLFIRI plus cetuximab and not Folfox because Folfox does cause neurotox. Why not use FOLFIRI? Why not use FOLFIRI plus cetuximab and not go with Folfox plus cetuximab? Because then you are able to use it for a much more longer period of time, and because of the neurotox and less neurotox with FOLFIRI plus cetuximab, and we have a phase 3 data for that.
Yeah,
So,
that
Dr.
is a
Manish, I'll just make a comment here.
Yeah, please.
Sir, so even I prefer actually Dr. Atul. And I used to prefer Folfiri because I really like the approach of Dr. Atul here. But my only issue was so when the patient comes to the OPD, it's a real world challenge. Inotican causes hair loss, which is very less with Folfox or Kpox.
Agree. Point taken.
I agree with that.
The patient has been
That's a wonderful
diagnosed
point, actually.
recently with a
No,
metastatic cancer, and you tell them that I have a chemotherapy which does not cause hair loss. They become so happy.
Dr. Manish,
Yeah.
Wonderful
one
point.
comment
Thanks,
here.
Priya.
Dr. Manish, one question here.
Yeah.
So once we use Folfox plus cetuximab in the front line and you drop at maybe probably 6 or 8 and continue with the maintenance and re-challenge with the oxaliplatin if it is there, that data also exists. Plus you have Folfiri plus bevacizumab which has the PFS and modest OS advantage also in the second line. So you have the potential good modality which is there following the first line data also.
There's no doubt on
So,
that.
I do agree
So
that there is
Shifali,
no sequencing
Shifali,
kind
that
of
brings
thing.
so
Yeah.
Folfox cetuximab taken, no hair loss. a better regime.
So
The only the
I'm
problem is
not
liver
concerned
tox.
about hair loss right now. I'm talking about the
No,
sequencing, which
that's a very
maybe.
valid point. I think you got to listen to your
Yeah,
patients.
No,
patient, yes,
no.
yeah.
So if patient is comfortable, of course, we need to listen to. But I'm talking of the sequencing evidence. I mean, do we have that thing that Folfiri and
Mhm.
Bev or
ये वो
Folfiri and
होता है ना, आपका
Cetuximab
बाल भी बांका नहीं
in
होगा.
no, no. I mean, leave apart the hair fall wala story.
So
That's all right. We have it.
honestly,
Yeah.
another theoretical advantage with the fall-free combination that for by any means, if you're not able to give infusional 5-FU, you can continue irinotecan plus cetuximab. But
Right, sir.
unfortunately, it's the same may not be true for the Folfox. If you cannot
Yeah,
give 5-FU, obviously you cannot give
yeah.
oxaliplatin.
So that is
Right, sir.
Yeah.
absolutely true, sir.
Yeah. That is
Because
true,
of
sir.
So
the bond study. Yeah.
yeah, that's what we are doing, sir. In few of the patients, we have Folfiri plus cetuximab, and we stop 5-FU, and we continue with irinotecan and cetuximab. So
No,
that is a
excellent
valid
approach. I
choice.
think
Yes.
one can do that. I agree because many people are quite wary of that infusion. Sir, do you have any concern of the concern that I raised of combining cetuximab with capecitabine?
No, I don't use that. And based on that data, and there's a lot of people have the concern it may not work. There's no synergistic action between the two.
Yes.
Right, sir. Right. So thanks for bringing that up. Shifali, from your point, I'm taking that lead. So is there any data on, or do you use, there is data, of course, the cricket and many other studies, the chrono study, etc. Do
Yeah.
you use actually cetuximab beyond progression? We use bevacizumab beyond progression. What is your comfort, or how do you use it if you have to use cetuximab beyond progression or re-challenge with cetuximab for that matter?
Yeah, so there is a difference with, I would say, between the re-challenge and reintroduction. So what I mean to say is, if it depends upon the PFS advantage or I mean, the time on which the patient responded to cetuximab-based treatment. So if it is a longer time, like patient has a good complete response or a partial kind of response for a longer time, then I think it makes sense in continuing beyond progression or re-challenging once the sensitivity is regained. That is what the data says. If the KRAS mutant clone is coming up in the resistant setting, and then once you give a break from the anti-EGFR and it works. But however, if the response duration is small, say patient progress while on 6 cycles of the same scenario, I don't think that re-challenge makes a difference here.
So
I
I'll give
don't.
you a case scenario. I'll go to Sumit. Sumit, I'll give you a case scenario. And this is a real case scenario.
Mhm.
There was a patient who had colon cancer, metastatic, bone mets, etc. And there was some bone mets also. And the CA started rising. The CA was around, say, 15. Excuse me.
Mhm.
The CA was around 15. It came down to 1.7 or something like that, and became undetectable and started rising again. And that was a time the patient was on Folfiri plus cetuximab and continued 5-FU, LV5-FU2 plus cetuximab as a maintenance therapy. But as the CA started rising, there was a proposal to do the liquid biopsy.
ctDNA. Hmm.
It showed that there is a small fraction of KRAS mutated population now.
Hmm.
Now there was confusion, and now the CT scan was done. The PET CT scan. The PET CT scan showed stable disease, but the CA is rising consistently, and there's a KRAS mutated population. What do you do?
See, there are two things. One, it is a stable disease, CA we can ignore. But again, if you have done a ctDNA which is showing a KRAS mutation population and CA is rising, then you need to act. So
You
what
need
I
to
will
act.
do is, I
So I was
probably,
repenting. Why did I do the liquid biopsy? I shouldn't have done it
yes,
because
exactly.
the,
Exactly. If you
no,
have done it, so what I will do, probably I'll stop cetuximab at this point of time. Maybe I'll add a biological or change the regime. Maybe I'll give it a try after 4 months or 6 months when there's a progression, because that we know the hypothesis is there. You give a break, 4 and 4.5
it's a
months.
small fraction. It's like if the tumor fraction is say 90%, KRAS mutated population, the KRAS mutation is about 1.2%
But it
fraction.
is it is likely to evolve, and probably it
It's
will
likely to
grow.
evolve.
Yeah,
But
probability
the
will
CT
grow.
scan is normal. Javed, what will
Yes.
you do in a situation like this?
So
If we have found that mutation is present, we have to change either what you said should have not done it, and imaging wise it is stable disease, because once mutation is there, everyone will ask, you are not acting. CA is rising,
Patient is
there
a
is
Supreme Court
evidence.
lawyer
And
and a very
No,
well-to-do lawyer.
you
I
Dr.
will
have to
Manish.
continue.
there you have to
I will
change. You have to
continue.
Shivali,
change.
No, Dr. Manish, I would disagree. I would not repent why I've done it. I should have done it. CA is I mean, he's a secretor. CA is a marker in his case. So
yeah,
the stable disease means that you have picked it up early. So why do you wish to get it spread? So act right now, just withdraw.
I had to
And then
act.
once the
There was no question not to act after a test. He's a
no, so
Supreme Court lawyer.
I would agree that I would not repent here. I would have okay appreciated myself. Okay, really I did it. Mutant clone, I
Priya, what will you
documented.
do?
She has left. She
I'm
has
recording
left.
this session. I'll make him here. Priya, what will you do?
I think Priya is left. Yeah,
Priya
she
left.
messaged.
Rajat.
Yeah.
Yes, sir. So I
So
would like to act. I would like to act on the new finding which has come. So it is almost like PADA one study, where of course we're talking about
right,
breast care.
excellent. What a corollary. Padawan study, yeah. The Faslodex story. Yeah.
Yeah.
So you like to act.
So
So we did act in the same manner.
and
So we
also
changed.
also if PADA one is one of course out of context, but the cricket study which says that the cetuximab re-challenge can happen later, and these clones definitely would
So
come up
they
more
tend
and
to die
more.
out. If you change,
Yeah.
the clone tends to
No,
die out, and
yeah,
then
I'm
you
saying
can
that the
re-challenge at
mutants
a
will,
later date.
yeah, the mutants would come more and more if we are continuously using cetuximab. So it's time to probably stop cetuximab, change the biological,
I
maybe
think very
change the
excellent
chemotherapy
comment.
backbone also, and then re-challenge.
Very excellent comment. I think that's exactly what we did. So we stopped cetuximab. We were bound to stop cetuximab. We changed to bevacizumab, and we did a lot of therapies. I'm proposing to repeat the liquid biopsy. I'm proposing the patient to repeat. No, he's not repeating it. He's saying why to repeat it. So
Good
and
point.
CA,
Good point now.
CA came down and is rising again, and he's reluctant to do the repeat liquid biopsy. There's no way that we can take a biopsy from a solid organ biopsy because it is in the bones. But then we are just continuing. I told him we keep doing PET CT scans. The disease is stable, but the repeat biopsy, the repeat liquid biopsy is if it says that the clone has decreased from 1.5% to now 0.2%, what would you do? Javed, still there, but it has decreased.
Uh, if he's
Now patient
progressing,
is off cetuximab, is on bevacizumab, and the clone has decreased, but yet there.
but he's still getting the benefit. CA is not rising, so I will continue.
He is rising on bevacizumab now.
So change
A
the
tricky
backbone.
situation. It's a tricky situation.
Tricky situation.
Re-challenge.
Change the
Re-challenge.
backbone. Continue
Continue
bevacizumab.
bevacizumab. Yes,
Yeah.
there is a data beyond
So we have
progression
given
also.
folfoxiri,
Yes.
bev, and the CA went down, now rising again on folfiri plus
Yeah.
or 5FU.
Yeah.
If
TAS plus
image is
bev.
not showing large volume progression, continue. There is a data beyond progression
Yeah.
also on that. Yes.
I'll
No,
probably
no,
continue. TAS plus bev. Continue.
TAS plus bev, okay. Any thoughts on TAS plus cetuximab? Now the KRAS is done with.
See, that study is coming up. I think Apollo, something like that is there. It's already
Yeah,
there,
there's
which
a
is
study which is coming up.
yeah. Hmm.
So TAS plus cetuximab study is coming up. There is
Yeah.
one study which is a smaller study. I think it's a Taiwanese studies
Hmm.
which they have done it comparing the two, and if they showed that if your the EGFR is sorry the KRAS NRAS is non-mutated, then you are likely to do better with cetuximab plus TAS 102. So there's a Taiwanese study if I'm not wrong. And last not the least, the BRAF mutated population. Are you using the breakwater regime?
Yes.
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 Encorfinib is not available.
Yeah.
Encorafenib is
Dabrafenib,
costly, expensive.
We
dabrafenib is
just
there.
imported for one patient. I'm using in one patient only.
So what
I
is the
don't
Very
have many.
reluctance
costly.
in using dabrafenib instead?
No, so dabrafenib, irinotecan, and this study is also there. You can use. No worries.
But in NCCN, it is not there.
Yeah,
The
It's
tissue
not
NCCN it
there
is
in
not.
NCCN. I am
Yeah.
using in one. It
So
is
Mm.
this
not in NCCN.
dabrafenib
So
studies,
I've
if
used
I remember,
dabrafenib
it
and
was the
tremetinib
second lines.
combination with cetuximab when the Beacon study came in, and
Yeah.
now I'm not using the tremetinib combination, the tremetinib part. I'm getting good responses. There's no
Yeah,
problem.
dabrafenib is,
Okay.
I think, the second line study, if I don't miss it.
There is one study, but
Breakwater
it is
is the
not the
first
frontline
line.
study.
Yeah, breakwater is the first line. So that is the difference here. So I have one patient on breakwater.
I
Yeah.
think we have our with our heads on our shoulder. I think there is no reason that we should not be using dabrafenib.
Yeah, it
Yeah.
It
is
is a
exactly. If it
So
is not, and Corafenib is not there, we can use what is
Yes,
there. Yeah,
doctor.
we have
yeah,
to
Dr.
support.
Manish and Dr. Sumit, I want your opinion on one thing here.
Mm.
So there is something, a challenging situation. So we have this patient who is on breakwater right now. So she was a adjuvant setting patient, and somebody did a BRAF outside and it came out to be positive. Now there was a lot of discussion that this patient is going to progress, but we don't have any data in adjuvant setting.
Correct.
We ended up using Folfox only in the adjuvant setting. She was T3N2 disease to begin with. And then after 4 cycle, as expected, there was a progression. Now, what to do in such kind of situation? You know, patient is going to have a poor prognosis. You know, she will progress. You know, you are going to introduce breakwater or dabrafenib at 4 cycle or 6 cycle or whatever time point. Then why to make it metastatic and not use it in adjuvant setting? So I agree that data does not exist, but what is your experience and take on that?
So we have adjuvant data of using BRAF inhibitors in melanoma,
Yeah, yeah,
right? So I think if if the patient has the confidence of the doctor, and these are
yeah,
not very toxic drugs,
yeah.
I think I would go out and use it.
है ना मतलब I mean the patient's question was there and I didn't have any answer कि doctor you knew that it would progress,
भगवान
you
ने
knew
इंसान
knew
बनाकर
that
भेजा है, बंदर
See,
बना के तो नहीं भेजा ना। तो तो
actually
इंसान
ये
अपना
तो
दिमाग तो लगाएगा।
लगाएगा
ऐसे
ही
कैसे हो सकता है कि नहीं लगाएगा?
correct
see,
correct
I'll have difference of opinion. See, my thing is कि probably the patient did not have any metastatic disease, any residual disease, so
no metastatic no
nothing
residual at
was
that
there.
time. No,
So
it was
and
T3N2M0
yeah,
clearly.
exactly. And these medicines, they have a duration of response. The responses are likely to work before the resistance comes in. Probably they will work for 4 6 months. So whether to use it when the disease is there and when eventually they will progress, whether you use it in adjuvant setting or the metastatic setting. Suppose you have
Sir,
used it in the adjuvant
So with
setting.
sir, I
about
yeah,
30% BRAF mutated patients have MSI high.
Yes,
yeah,
BRAF mutated patients have some immune system dysregulation, which can be set right by immunotherapy. I
yes,
think treating them early on when the disease is minimalistic
yeah,
may trigger an immune response, which will not, for there's no proof of that.
correct.
It's only theoretically, I'm trying
Mm.
to discuss this, that you may have some patients who go into deep remission because of early usage of the BRAF inhibitors.
Inhibitors. Maybe that
yeah.
may.
And because
I do agree, Dr.
I'm
Manish,
taking the
that
corollary
perspective.
from the melanoma studies, where
Mm.
adjuvant studies has resulted into overall survival benefit. And
Yeah,
that's exactly what I'm trying to say. That if this patient has a significant risk of recurrence, an adjuvant BRAF inhibitor may result into some overall survival benefit. We don't have that proof in
Yes.
colorectal cancer, but if you take a corollary from melanoma, I think you have reasonable scientific reasoning to give it to a patient who understands you, who understands the science, but you will seldom get a patient who understands the science to that extent.
Yes.
yeah. Now the second thing would be because it's an adjuvant. Would you add on encorafenib, cetuximab also, and then Folfox? So that would
Wow.
be.
Adjuvant cetuximab. Absolutely not.
So that is why encorafenib has this arm. I mean,
So,
so how do you treat then BRAF in adjuvant?
good question. I think that's Shifali, that's a nice question. So we know that now when you have level one evidence that cetuximab in adjuvant study,
Does not
like the
work. Mm.
PTOC 8, or
Absolutely.
for that matter, the
Yeah.
new epoch study, in the adjuvant study, it did not result into any benefit. I am not for cetuximab. If you
Yeah,
want to
I
add,
do agree. But only encorafenib and chemo, there is no
It does
data
not
to
work.
work on.
Yeah, it
Yeah,
does
so
not
that is
work.
why
So that
I
means you
think
are
Dr.
not going to
Sumit has
use
a
it.
point that
Hmm.
it is difficult to use in
Yeah,
this setting. Yeah.
yes, it is. That's why I said ki use it in
Perhaps in a
metastatic.
patient who has a locally advanced disease, you use it as a neoadjuvant study. We have
Yeah,
Foxtrot study.
absolutely. Yes.
Foxtrot study showed Folfox can benefit. It was not a statistically significant study, but the Foxtrot study was one study which used neoadjuvant chemotherapy for just about 3 doses or 4 doses of Folfox and showed that there is some improvement in progression-free survival of patients who use it as a neoadjuvant strategy just before surgery and then topping it up with the adjuvant arm. So in that setting, if you have something that you really wish to give, you use it as a neoadjuvant rather than as an adjuvant therapy.
Yeah.
Yeah,
Just
good
one
point.
thing I would like to add: whatever it is, do not give EC alone.
Yeah.
Add it, combine it with chemotherapy backbone.
Yeah. Do
Yeah.
agree.
Mm.
Yes.
So I think with that we had a very nice discussion. Thank you all the
Mm.
panelists for that very lively discussion. And over to Dr. Yogender. I didn't use any of your slide set. I think it was more interactive than going through the slides. I think slides were already touched upon by Dr. Ankur very nicely. And over to you, Dr. Yogender. Thank you,
Absolutely,
panelists.
sir. Yeah. Thank
Thank
you
you,
so
Dr.
much,
Manish.
sir.
Yeah, thank you, everyone.
So we are already ahead of time, over the time, and Dr. Atul has already left, and I think Dr. Priya has also left. So I would like to thank everyone, each one of you, to our faculty for taking out time for this important meeting, and particularly to our moderator, Dr. Manish Singhal, for driving this panel discussion so immensely beautifully and clinically relevant. Uh, and also, I'd like to thank our eminent panelist, Dr. Sumit Goyal, Dr. Javed Mujammil, Dr. Shifali, Dr. Rajat Bajaj, and Dr. Priya Tiwari. She is not there. And Dr. Ankur Bhal, thank you so much for taking the session. It actually laid the platform for this discussion. And with this, it formally comes to the meeting formally comes to the end. And I wish you a very good night and a very good weekend. And we'll uh, look ahead, looking forward to meet again in similar intensive discussion in the future, near future.
Thank